Welcome to Governing Pandemics 101, a course offered by the Global Health Center of the Geneva Graduate Institute. My name is Charles Deutscher. I'm a policy advisor at the ICRC, the International Committee of the Red Cross here in Geneva, where I work closely with our health unit.
And I am Esperanza Martinez, medical doctor and general surgeon, and currently a senior advisor in the Office of the Director General of the ICRC in Geneva. Before we delve into the subject, it is important to provide some context. First, the organization we work for, the ICRC, is mandated by states to assist and to protect people affected by armed conflict worldwide. And this mandate is enshrined in the Geneva Conventions and international humanitarian law. Therefore, the perspectives we will offer in this session come from this angle. The second point is that it's important to define what populations and areas outside of a state or government control are, and why do they matter when we talk about pandemics and epidemics. So Charles, why are these areas important and what they are?
One way to define areas not under the state control is to define them as geographic areas where the authority of state institutions like ministries of health, law enforcement, are weak or where they're not existent at all. In place of state authorities, there might be the authority of, for example, non-state armed groups, many of whom the ICRC engages with. Some of these areas which may come to mind include areas of south-central Somalia or northeastern Syria. And given that healthcare is primarily the responsibility of states to provide, this is a problem for people living in those areas. And by our 2021 estimates, the ICRC estimates that around 100 million people worldwide live in areas under the fluid or complete control of what we call non-state armed groups. Why is this important for public health? Well, it's important because in the 3 decades to 2009, for example, up to 70% of epidemics and pandemics originated in areas affected by armed conflict. And in those areas, some of those areas are controlled by non-state authorities. And why is this so? Because it's harder to provide healthcare in these areas because health systems are weak, health workers are attacked. It's difficult to get provisions, for example, due to difficult terrain and insecurity, and there's very weak infrastructure. So in a way, working to strengthen health systems and the outcomes, health outcomes for people affected by armed conflict matters around the world, even if you don't live in one of those places, for epidemiological reasons, because we know, and we've heard many times during the COVID pandemic, that no one is safe until everyone is safe, and that's true. And it also matters for moral, political, and economic reasons as well.
In addition to those populations, and the issue of geographical areas under the control of non-state authorities, there are also specific populations that are often forgotten in public health interventions, including those to control epidemics and pandemics. And these are, for example, people deprived of freedom, prisoners, or people that are displaced, either within their own territories, internally displaced, or across borders, refugees. The case of detainees is an interesting one and of particular importance for the ICRC because their health very often and in many countries don't fall under the jurisdiction of the Ministry of Health. So the health interventions are either the responsibility of the Ministry of Defense or the Ministry of Interior or another ministry. So here it is very important to ensure that public health interventions to coordinate efforts in pandemics and epidemics are coordinated with other ministries and institutions within a country. These populations that we are referring to and those living in not under state control are very often referred as populations in the last mile. And this definition really encompasses populations for whom the government is unwilling or unable to deliver healthcare services and whose risk is heightened because of the lower provision of essential services. So talking about these populations of concern leads me to the first point of this session, Charles. Prior to COVID, what international arrangements were in place to ensure the health of populations that are not protected by the state during pandemics?
Thanks, Esperanza. If we consider the pre-pandemic, pre-COVID environment, one way to think of what we might call the global health system is at global level and then national and subnational levels. So the global level really provides the frameworks, the standards, and the governance mechanisms. So you all know the WHO, the World Health Organization, an organization composed of member states which has a mandate to improve global health. It is the custodian of the international health regulations, which is a binding treaty which contains obligations, again, on member states to prevent and control epidemics and pandemics. Also applicable to conflict settings, which is where many people who don't live under state control reside. Esperanza mentioned in the introduction international humanitarian law, or the laws of war. That body of law also contains obligations, not only for states, but also on non-state parties to armed conflict related to the prevention and the control of epidemics. For example, protecting vaccinations and vaccinators as medical services and products. So these are the standards, and clearly WHO plays a very important role in setting those standards based on the science and coordinating the international response, as we've seen. But if you think about what we're really concerned about, the delivery of healthcare, most of that happens at national and subnational level. The responsibility for the provision, the delivery of healthcare to populations in geographic areas is fundamentally a state responsibility. And so you can see the challenge where many people are not living in areas controlled by the state. We have to try to find ways to support existing mechanisms, existing healthcare authorities, without creating parallel health systems. So now we've covered the pre-pandemic setup. Could we turn now to speak about the weaknesses that COVID exposed during this pandemic in these international arrangements?
Thank you. The COVID-19 pandemic exposed a number of inequities and weaknesses in global coordination mechanisms, including in terms of financing, in terms of procurement of health goods, and organizational mandates. I think the most glaring example is inequity in access to global health goods and services, including access to personal protection equipment, oxygen, and more recently, vaccines. Inequity exists between countries and within countries. And one of the things is that at some point we have countries that have vaccinated more than 90% of their populations, while others, many of them affected by humanitarian crisis, including by armed conflict, have less than 2% of their populations vaccinated, and that included even healthcare workers. This inequity could be attributed to a number of factors. On one hand, we have unprecedented scientific collaboration that developed in record time a number of effective vaccines. But on the other hand, we didn't have effective mechanisms that allowed and ensured equitable distribution of those vaccines, and therefore, as a result, we saw countries that have purchasing power having greater capacity to vaccinate their populations compared to low and middle income countries. To resolve this and to try to ensure more equitable access, and particularly as well access to vaccines for populations affected by humanitarian crisis, this mechanism, the COVAX mechanism, was created with the leadership of WHO and many other organizations. And within that, a specific mechanism called the humanitarian buffer to ensure that delivery of vaccines reach the most vulnerable sectors of the population. Unfortunately, it took months for the first vaccines to arrive into the mechanism and for them to make it to low and middle income countries. At financing level, global mechanisms focus on the production and the delivery of vaccines. But vaccines have to be administered to people, and this happens at the local level. So one of the things that we saw, and a big gap, was the financing of local systems, supply chains, and even healthcare workers. And this is a fundamental gap that we have in this pandemic. More challenging, and we have seen this in our work, is that for populations that live in areas controlled by non-state armed groups, financing or local capacity is extremely challenging because most of the financing mechanisms come through state government setups. Finally, from a public health perspective, a big challenge is that very often activities and public health interventions in a pandemic or an epidemic are standing alone activities, not only in terms of prevention, but also in terms of vaccination. And this poses a number of problems for populations that live particularly in low and middle income countries or affected by humanitarian crisis, because they have so many other needs. They might be lacking water, access to sanitation, access to food, and therefore, if we ignore those other needs, it's going to be very challenging to mount a humanitarian or a public health response. So when we move forward, and one key lesson we need to learn from this pandemic is that we need to embed public health interventions for pandemics as part of a broader health response, not a standalone activity. This covers some of the challenges we are facing today. Moving forward, the question is, what kind of reforms do we have on the table, and what do they aim to achieve?
Well, one set of reforms which is already on the way concretely in different countries, I think is worth flagging, which really harnesses or tries to pick up some of the points that you just mentioned, Esperanza, is the Country Readiness Partnership that's led by WHO. And it focuses on some of the countries where less than 10% of the population is vaccinated against COVID-19. It's trying to learn the lessons also of previous epidemics like Ebola by bundling vaccinations within other healthcare services that populations need more, maternal and child health, for example. It's also bundling these healthcare services like COVID-19 vaccinations within broader humanitarian services, social services that might respond to what we call the secondary impacts of a pandemic as well. I think it's worth flagging because it's something that's happening right now in 34 countries affected by, many of them affected by armed conflict and violence. But longer term and even more globally, I think it's fair to say that the COVID-19 pandemic exposed gaps in the international public health architecture that's set up under the international health regulations that we spoke about, including the ways in which countries share epidemiological information and health products. And so there is now an ongoing process to strengthen implementation of these international health regulations by developing a pandemics treaty or other legal instrument. Arguably, what is required more than a new instrument is actually better implementation of the existing international health regulations. But the intention around the issue does show a certain degree of political will, I think, to address some of the gaps that were exposed in the pandemic. There are also proposals to address the issue of health financing coming out of the G20, which may help strengthen what WHO calls the 6 main building blocks of health systems, which are required, of course, to deliver healthcare at national and subnational levels where it matters most. And I think one issue there that will be interesting to see is how issues of sanctions and counterterrorism, so funding not going to previously non-state armed groups, is dealt with.
So this brings us to the end of this session. Please complete the quiz, and thank you very much.
Thank you.